Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. The October issue of Health Affairs explores the relationship between disability and health. Now, conversations about disability often begin with the statement that 1 in 4 U.S. adults have a disability. But what does that mean? Disabling conditions are varied, and the people who experience them are equally varied. A discussion of disability policy, its successes, failures, and what more needs to be done must begin with an accurate picture of the population with disabilities. What we mean when we say disabled, how we come up with estimates of the size of the population with disabilities, and how to approach the health disparities we observe are the topics of today's episode of A Health Podyssey. I'm here with Linda Long-Bellil, Assistant Professor at the University of Massachusetts Chan Medical School. Dr. Long-Bellil and co-authors published an overview paper in the October 2022 issue of Health Affairs on disability and health. Utilizing a biopsychosocial definition of disability, Long-Bellil and co-authors find that health disparities among people with disabilities exist along race, gender, and sexual orientation lines. They make a number of recommendations designed to promote more equitable outcomes. We'll discuss these in today's episode. Dr. Long-Bellil, welcome to the program.
Thank you very much. I'm pleased to be here.
Since you wrote an overview paper, I think it's good that we start with some of the basics that, particularly thinking about terms that tend to roll off the tongue like disabled. And one thing you start with in the paper is to note that even our conceptualization understanding of disability has changed over time. Can you say a little bit about that?
Well, let me just start by saying there's no perfect definition of disability, but the definition of disability has kind of evolved over time. Initially, it started with what we call the medical model, where disability was seen as purely a characteristic of the person, a characteristic of the person's body or mind. And then over time, activists in the disability community, starting in about the 70s, started saying, no, disability isn't located in the person. It's located in the environment. It's the environment that's disabling. There are physical barriers. There are attitudinal barriers. That was what we call the social model. Over time, what has evolved is more of an interactive model of disability, where elements of the person's body and mind, along with aspects of the environment, the physical environment, the social environment, attitudes, etc., combine in this kind of synergistic relationship to create disability. That's where both healthcare and health policy happen, and that's what they need to address. They need to address the interface between the body, the mind, and the environment.
So that seems like a really helpful way to think about it, and it's interesting to see the shift from a purely medical approach. Now, we throw around numbers of people with disabilities. I doubt we're probing all of the medical and social and environmental phenomena. So when we say a quarter of people have disability, where do we get those data from?
That particular number, and there are different numbers in different surveys, and they vary depending on the specific questions asked and the survey methods used. Those particular numbers, I believe, come from the CDC, which uses the Behavioral Risk Factor Surveillance System. That particular survey focuses on functional limitations, asking questions like, do you have difficulty climbing stairs, things like that. That's not an exact quote, but questions like that. That's where that particular number comes from.
Now, your paper is chock full of data, and I'm not going to ask you to read tables because that's not interesting on a podcast. But you do have a lot of data in there about the prevalence of disability and its incidence across various groups. And I wonder if you could just give us some of the top line sense of some of those topics.
Well, let's see. Across racial and ethnic group, people who are Black have a slightly higher prevalence of disability than whites, and this increases when you adjust for age. Latinos, Native Hawaiians, Pacific Islanders have a lower disability prevalence than whites, but when you adjust for age, those differences disappear. So members of the LGBTQ community are at a higher risk of disability. Folks who are gay, lesbian, bisexual, etc., are significantly more likely to be disabled than heterosexual individuals.
So if we're trying to figure out policies to reduce some of the inequities experienced by people with disabilities, if we start with, say, mobility limitations, so that's a prevalent disability, and you might think what kinds of interventions are needed to target that, and that would benefit some subset of the population, but others who have other kinds of impairments might say, well, that's great that that's there, but it really doesn't address the needs I have.
Well, universal design is one approach. We didn't really mention that in our paper, but universal design is something that could benefit all folks with disabilities, because it would mean that environments would accommodate people with a wide array of needs. Also, compliance with the Americans with Disabilities Act, providing accommodations to people who are, either have mobility impairments, or who have visual impairments or hearing impairments, who are deaf or hard of hearing. Accommodating folks willingly and gladly would definitely go a long way addressing some of the environmental barriers that people deal with.
Well, you've introduced the topic of policy, which takes up a good portion of the overview paper. So I'd like to spend a little more time with you on, you mentioned enforcement of existing laws. The paper also mentioned some new policies that might be helpful. We'll dive a little bit more into that after we take a short break. And we're back. I'm speaking with Dr. Linda Long-Bellil, who is a co-author of one of the overview papers in the October 2022 issue of Health Affairs that focuses on disability and health. The paper does focus on the issue of equity and the inequities that exist within the population of people with disabilities, as well as between people who have a disability and those who do not. You go into some detail about some things that we could do that would be helpful. Just before the break, you mentioned both universal design, which isn't in the paper, and enforcement of the Americans with Disabilities Act. Can you tee up some of the other policies that you mentioned that you think would be helpful?
Sure. Well, the Affordable Care Act did a lot to improve access to health coverage for people with disabilities by reducing the prevalence of pre-existing condition exclusions, creating premium subsidies, expanding Medicaid in those states that agreed to expand Medicaid. Something else that I think could improve access to health coverage for people with disabilities is to improve the existing Medicaid BuyIn programs. In the 1990s, and actually, let me just start. The very first Medicaid BuyIn program was created here in Massachusetts by Chapter 23 of the Acts of 1988. It's called Common Health, and it allows people with disabilities who meet the Social Security standard for disability, and we could have a whole webinar on that, a whole podcast on that. But suffice to say that program basically said that anyone who meets the Social Security standard for disability can obtain Medicaid without any income or asset limits simply by paying a premium, and the premium is a sliding scale premium, which increases with your income. This idea, the general idea, was adopted at the federal level, and in 1997, in the Balanced Budget Act, provisions were passed that made a Medicaid BuyIn program possible for other states. However, most states impose a fairly stringent income or asset limit, better than the standard Medicaid income and asset limits, but still low enough that they keep people with disabilities either in poverty or very near poverty. And so an improvement in the BuyIn program could be that they get rid of those, that the federal, actually what would be the most practical thing would be for the federal government to increase the federal matching percentage for states that agree to eliminate the income and asset limits.
So I want to stay here for a moment, maybe in part because my first job out of graduate school was implementing Chapter 23. So this is very, very near and dear to my heart. Although I wasn't working on Common Health, but I was working on other elements of it. So it takes me back. So I want to go back there with you.
Okay.
So the idea here is that Medicaid offers a comprehensive set of benefits, much more comprehensive supports in particular for people with disabilities than traditional commercial insurance. but standard Medicaid eligibility thresholds may exclude people with disabilities from Medicaid coverage. So you want to open up the benefits to people who would find it worth paying into the Medicaid program at presumably a pretty significantly subsidized premium, but they're at least making a contribution. It enables them to keep Medicaid as they're employed. And then they get some of the wraparound benefits that Medicaid offers. Is that how it works in Common Health?
Exactly, yes.
And do we have a sense of why other states, is it just a budget reason that other states don't take this up?
That would be my guess. I don't have proof of that, but that would be my guess.
Seems like a reasonable supposition, doesn't
Yes.
it? And that's why
usually
you suggest,
that's how things work, right?
Yes. So that would make it why you would start with a possibility of increasing the match rate. So that's a very interesting opportunity. And what it's basically saying is we have a program that already serves a large number of people with disabilities. It's done a lot of work to try to figure out how to meet those needs. If more of the people with those needs were in that program, it would help close some of the gaps. Are there other policies in your overview paper that you'd like to draw attention to?
Sure. One thing I'd like to see is states to continue what started with the Olmstead decision and expand access to home and community-based services by rebalancing, continuing to rebalance the distribution between institutional and community services. States have, I think, slowly been trying to develop more community-based services for people, but it really varies. It varies tremendously from state to state. So I'd like to see more progress on that front. There is federal matching available under some programs, increased federal matching available under some programs for that. So there is an incentive there.
Yeah, so we recently, a number of years ago, passed the 50% mark, where more than half of the spending on long-term supports and services in Medicaid is now non-institutional, but that still, as you note, there's significant variation from state to state, and it still leaves a large share inside institutions. This may not be a fair question, but I'll ask it nonetheless. One of the papers in our October issue did note that rates of nursing home utilization among people under 65 has not fallen at the same rate as people over 65. A lot of these efforts to move people out of institutions have been focused on elders. Do you have any insights into what might be helpful for achieving some progress for younger people with disabilities along the lines of what we've had for older adults?
Well, I think building a more robust community system, community-based care system, I think would definitely help. I think some young people with disabilities do have family supports. Some of them may not, and so there needs to be a very robust, professionalized system. There are also issues like access to housing, support, including supported housing. I think that those are both concerns as well. So I think there are a variety of policies that could be employed to get more younger people out of nursing home facilities.
One of the first policies you mentioned were changes ushered in by the Affordable Care Act, and I didn't follow up on that, but I'd like to now. When people talk about pre-existing condition exclusions and getting rid of them or getting rid of lifetime caps, I think most people have in mind people with very high medical costs. That's not synonymous with having disability. So say a little more about why these changes are important for people with disabilities.
Some of it is the kind of the home care services. That's some of it for sure, because you can be relatively medically stable but still have meaningful support needs. That would be one thing I would think about when answering that question.
Yeah, it seems to me the overlap between sort of disability and high medical costs, they're different but related, and I am struck that when we had sort of a political debate over pre-existing conditions, for example, the image that was sort of put forward was not really of people with disabilities, of people with chronic conditions, which may or may not be disabling. So I think trying to understand the implications for people with disabilities of some of these provisions is really important, and maybe wasn't as much attended to at the outset.
Well, I mean, there's so much variation within the disabled population. I mean, you do have people who have very high medical costs, and it does help those individuals. And then it really ranges the gamut. I mean, on average, people with disabilities do have higher health costs than other people. That is certainly true. So it does help people with disabilities. The getting rid of pre-existing condition exclusions or minimizing them did help folks with disabilities.
The title of your paper and the early conversations we had drew on the concept of equity. Certainly, the policies you've mentioned, which would be helpful to anyone with disabilities, would have an equity improving element. But I wonder if there's more you could say about the pursuit of equity in this area.
Well, I think expanding the scope of services covered by public and private insurance. In the paper, we talked about medical necessity definitions. And medical necessity definitions can be very, very limiting. They often are not focused on, trying to help people live independently in the community. And one state that has a good medical necessity definition is Delaware. Its medical necessity definition refers explicitly to the aim of attaining or retaining independence, self-care, dignity, self-determination, personal safety, and integration into all natural family, community, and facility environments and activities. So it really has this. It legitimizes the goal of getting people involved in the community, promoting inclusion in the community as an aim of its medically necessary services, and that services that do those things are considered medically necessary.
Yeah, so I want to discuss for a moment the implications of that. I mean, basically, medical necessity is a requirement for insurance to pay for services. If they're not medically necessary, then they're not necessary. So that actually has really significant implications. And I suppose for when you think about the needs of people with disabilities, there are, listening to you read the definition in Delaware, there are many things that are really important to a life of dignity and participation and inclusion that are not curative, which I suppose is sort of the easy part of medical necessity.
Right, yes. Traditionally, that was the focus, sort of survival. I think pure survival was the focus, curative, improving someone's medical condition. But there's so much more that people need. And so I'm really pleased to see a definition like this one.
So as we come to a close, I wonder if you could just say a little bit about any work you're doing right now, going a little deeper into your own areas of particular interest within disability policy.
Well, let's see. I am doing some work with our integrated care program for dual eligibles here in Massachusetts, and that's a very good program. One way to try to address concerns about cost while addressing the need for people to be included in the community and have broad definitions of medical necessity, et cetera, is to use services like care coordination and to in a thoughtful way that promotes community inclusion, manage care. That's one approach. Something else, I know that Lisa Iazzone's article talked a lot about the challenges people have in obtaining medical care, and they're very real. They're very real. People with disabilities have tremendous difficulty accessing medical care. Unfortunately, clinicians are not trained to provide that care to people with sort of obvious disabilities. So significant mobility impairments, blindness, deafness, intellectual disabilities. Typically, these services are not required, or rather, I should say, the training is not required in medical schools or residency programs, and so it gets overlooked. So that's a real challenge for people as well. I know that the AAMC, the American Association of Medical Colleges, is has embarked on a diversity and inclusion effort, and I believe that they have, to at least some extent, included disability within that effort. But and so hopefully maybe that'll improve over time. But disability still isn't included on any of the licensing exams, and so what gets measured gets done, right? And so it would be important for there to be some progress on that front as well.
Well, Dr. Bellil, thank you for writing the overview paper with your co-authors and for explaining sort of the terrain here so that we can have a better understanding of the needs in the population. Thank you for that work, and thank you for being my guest today on Health Podyssey.
Thank you. My pleasure.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about the Health Podyssey.